Good afternoon, everyone. I'll be presenting my study on the comparison of predictive accuracy of partial coherence interferometry and swept source OCT-based biometers for IOL power calculation in a pediatric population. Optical biometry is now the gold standard not only for adult but also for pediatric populations. Among the two biometers we have studied, IOL Master is the more commonly used one based on partial coherence interferometry. It uses a light source which has a 780 nanometers wavelength, and the axial length measurement uses a single refractive index for all tissues. Argos is a newer SSOCT-based biometer using a light source of about 1000 nanometers. It uses refractive indices which correspond to each tissue, which gives an improved tissue penetration, better image quality, and improved signal-to-noise ratio theoretically. Recently, there have been studies comparing both these barometers in adults undergoing cataract surgery. However, there is a lack of literature comparing the predictive accuracy of these biometers in a pediatric population. Therefore, the purpose of this study was to compare the predictive accuracy of IOL power calculation made with these two biometers based on different principles in children aged 5 to 15 years. This was a pilot study in which we included 5 to 15-year-old children diagnosed with developmental cataract. We did preoperative IOL power calculations using both IOL Master and Argos biometers. The axial length, keratometry, anterior chamber depth readings were obtained. IOL power was calculated using the SRK-T formula. All patients underwent lens aspiration, primary posterior capsular excess, and anterior vitrectomy, and the IOL placed in the bag for all patients. Refractive outcomes were measured at 4 weeks post-op by manual refraction. The prediction error was calculated at the post-operative spherical equivalent minus the predicted spherical equivalent. And we measured the absolute prediction error and the mean value of absolute prediction error. These statistics were performed using the SPSS software. Mean K, axial length, anterior chamber depth, prediction error, and absolute prediction values were compared using the Wilcoxon sign rank tests. Pearson correlation coefficient was calculated for each parameter, and statistical significance was p-value of less than 0.05. So in our study, we had a range of 8 plus minus 3 years. The predictive mean prediction error was comparable in both the biometers, and the mean value was 0.59 in the PCI-based biometer and 0.46 in the SSOCT-based biometer. There was a strong positive correlation between the biometers for axial length, keratometry, and anterior chamber depth readings. And the difference in the mean absolute prediction error was not statistically significant. These are the histograms showing the mean absolute prediction error values for Argos and IOL biometers. In the discussion, there have been studies which give varying results. There are studies done in adults in which both these biometers based on SSOCT and PCI base have shown good correlation between the values. However, some studies do report that in medium-long eyes, the SSOCT-based biometer gives better results. The limitation of our studies was that we included children in whom biometry was successfully performed between both biometers. Therefore, success rate of acquiring the measurements was not examined. Also, we only took children above 5 years of age, which excluded children younger who have more chances of prediction error in calculations. In conclusion, pediatric, the predictive accuracies of PCI-based biometer, IOL Master, and SSOCT-based biometer, Argos, were comparable. We found a strong positive correlation between the two biometers for axial length, keratometry, and anterior chamber depth values. Therefore, an SSOCT-based biometer could be a useful tool in preoperative IOL power calculation in children. However, we do recommend that future research with a larger pediatric study population with varying axial lengths is warranted. Thank you.
No, because your mean age was 8 something.
Yes, sir.
So by that time, the development of eye is already completed. So what is the real aim of your study?
So we do, because there is a availability of newer biometers, we do want to compare between whether the commonly used biometers like IOL Master.
No, my point is simple.
Yes,
because how these kids are different than adult, because all the development has already taken place. My point is this. So what is applicable for the adult, this would be applicable for 8 year plus old child. My point is that. So how it is going to different for that? because we need, we are facing difficulty between 0 to 2 and 2 to 6 most of time. So that is the dilemma for most of the pediatric ophthalmologists. After 8, things are very much clear like that. Even so, that's why I'm asking what was the aim for your study?
If we do the study, then it is
Acha,
it is
would you want
better
to
clearer.
contribute for the literature?
Yes.
Okay, fine.
Thank you.
And you are the main investigator or somebody else has?
I am the main investigator, sir, under the guidance of my chief author,
Okay, okay. Who is your chief? Dr.
Dr. Sumita Agarkar, ma'am.
No, no, that's okay. Means like, is it your consultant,
Consultant,
or
yes.
your teacher?
My teacher, yes.
Acha, acha, okay, fine.
Dr.
Yes.
16. So power of the study is very low. 69.
That's why I'm saying.
The study is very low. They will have to do hundreds of patients to get accuracy.
Because he is a very young, so we want to just give some insight to do better studies and all that. That is the idea only.
Yes.
Thank you.